So we'll move on to the last talk of this session. I'd like to invite Dr. Zain Khatib, sir, to speak on frugal innovations in refractive surgery.
Yeah, thank you, Yossi, for the opportunity. But Dr. John spoke in general. My talk is, related per se to refractive surgery. So I think since not many of us are doing refractive surgery here, I'll just try to keep it as simple as possible and try to explain what I have done. Basically, refractive surgery we know is a very industry-driven branch. So doing frugal innovations is that much more important in this field, since we need to do things ourselves to solve problem rather than you will give it to the industry. They'll give you a heavy bill for it. So I'll just talk about three problem statements that were there, and which I addressed with small things on my own. So the first one I think is something really important, that is the protection of the retracted LASIK flap and hinge while doing the excimer laser ablation. So whenever you have a large ablation zone, be it in hyperopes or astigmatism, you can ablate the undersurface of the retracted flap and the hinge, and this leads to really bad coma. I just came up with a very simple design, gave it to Epsilon, and I got a kind of cataract globe stabilizer slightly modified and made it into a LASIK globe stabilizer. Now, why I say globe stabilizer is because the purpose of this instrument was not only to protect the flap but also to stabilize the globe. So, modern laser machines, they have eye trackers which move along with the eye, but there is a small latency, and that latency period leads to terrible aberrations. So, it is extremely important that the eye is well centered during surgery. So I'm actually in the process of collecting my data and publishing. So you see here the two laser spots are slightly defocused. I use the instrument to just press down slightly so that it focuses, and the head of it is protecting the undersurface of the flap. And now we are going ahead with the ablation. It's well centered, focused, and the flap is not getting ablated. This is a hyperopic treatment. You can see the flap is would get ablated if the instrument wouldn't be there. So if you see my instrument, you can see the crater in the center of my instrument is what the instrument has taken by laser, which would have otherwise gone on an undesired portion of the flap. And the patient may not present in terms of loss of visual acuity, but these are the patients who we don't understand why exactly they are having problems post-op. This is just to show you how we track the centration after surgery. So the last one shows you that if it's well centered, that is where you want to achieve after every excimer laser ablation. Right. So that was one of the innovations I had made. Now the second one is again it's a continuation of this. If at all you have a patient who's 6/6 post-op and they are unhappy, they have glare, halos, night vision problems. Okay, we have tests like your modulation transfer function, Strell's ratio, point spread function, aberrations, but these are all objective. How is the subjective way that you can assess whether a patient is happy or unhappy? The only test that we have is contrast sensitivity, peliropsin, and peliropsin actually doesn't test contrast sensitivity, it tests contrast acuity. So if a patient has very, very low contrast, then only it will be picked up on peliropsin, and slight changes in contrast will not be. So this is the test. You need grating acuity. You need to show sinusoidal frequencies at the standardized ones are 3, 6, 12, and 18. And once the patient is able to identify the sinusoidal gratings, you have to plot it on a chart like this, and this is called as contrast sensitivity sinusoidal grating. It is very useful to pick up if the patient is unhappy. It actually correlates with modulation transfer function, but in a subjective way. So this device which measures this is called as CSV1000. It's by only one company called Vector Vision in the world, and the company distributing it in India is called Jutron Vision. So what is the problem? The problem is that this device costs 7 lakhs. So you're not going to pay 7 lakhs to test contrast. So you have to take that chart, you have to test it, and then you have to manually draw it on the sheet that they give you for the plotting. So I decided to go ahead and make this on my own. I used PowerPoint. I just got all the gratings in order. I adjusted the screen brightness to match what is the set 85 candles per meter square, and I've been using this thing on my own. And I even designed a Excel software where you don't have to manually draw it. You just have to feed in the score and the software will give you the chart. So this is something that is really useful for measuring whether the contrast sensitivity of the patient is good or bad, and it actually picks up even if you've got a multifocal IOL which is giving the problem. You can see whether the contrast is actually low or no. So that was the second thing I was speaking about. The third thing is slightly more complicated, but I'll just keep it simple. So this is some kind of passion project of mine, say for the last 2 years or so. Understanding astigmatism. It's a complex topic, but many times we treat the patient with the refractive error and we realize that they are left with a post-op cylinder for no reason at all. Why should this cylinder be there? The reason is because astigmatism is complex. It comes from different parts of the eye, right from the brain up to the anterior surface of the cornea. And it is important to understand which part of the eye is contributing to the astigmatism before we treat the patient. So in simple terms, the difference between the corneal astigmatism and the total astigmatism is given the name as ocular residual astigmatism. And patients who have high ocular residual astigmatism, there have been enough studies to show that they are the ones who have the post-op residual cylinder. So I designed my software to basically understand from where the astigmatism is coming and correct it adequately. So just to give you an example, for this patient who had minus 1.75 diopter cylinder in both eyes, she was a 36-year-old female. If you just see the her corneal astigmatism, it is 0.45 in the right eye, 0.25 in the left eye. This is like really low, and her manifest cylinder is 1.75. So my software gives you the components of the astigmatism. So you can see here most of the astigmatism is coming internally from the lens, and then it uses vector mathematics to give you what should be the final correction. And in this case, in the right eye, instead of 1.75, the software is set to correct 1, and in the left eye, instead of 1.75, the software is set to correct 0.75. So this patient was extremely happy post-op, and you can see that the cylinder post-op is also 0. So if we would have gone ahead and corrected 1.75, she would have definitely got a residual cylinder left. So this is something that I've been working on for some time, and I won the ASCRS award last year for this software. So these were some innovations related to refractive surgery that I've been doing, which I wanted to share. Thank you.
Thank you so much, sir. I hope you're planning on starting a refractive fellowship program if you haven't already, because this is really game-changing things. And I think the last thing just went over my head, but regarding the other things, I think a lot of people would benefit from.
Unfortunately, the whole idea of fellowship in India is that we should have volume of surgeries. So if you don't have volume, you can't start a fellowship.